Sedatives, primarily barbiturates, bromides, paraldehydes, and chloral hydrate, were the only medications available until advent of antipsychotics and antidepressants till 1950s. In 1934, neuropsychiatrist conducted the first experiment in treating patients with schizophrenia by inducing repeated seizures. Maduna found in his neuropathology studies that glial cell concentrations in the brain of the patient with epilepsy were much higher than normal, whereas glial cell concentrations in brain of patients with schizophrenia were much lower. So he hypothesized that seizures may be protective against psychosis and that inducing conversions in patients with schizophrenia could reduce symptoms. In 1917, Professor Wagner Jurag of Vienna marked advancement in diagnosis as a cure for patients
which give rise to theory of biological antagonism.
biological
Biological antagonism, induction of all
biological antagonism is induction of one illness could treat another. Professor Wagner was awarded Nobel Prize for Medicine in 1928 for the same. Lucius Cerulli and Hugo Bini in 1938 first induced seizure in a catatonic patient by electric stimulation and produced a successful response. In 1978, American Psychiatric Association has recommended the use of ACT in treatment of psychiatric illness. Coming to mechanism of action, basically it is unknown, though there are some possibilities regarding its effectiveness in psychiatric illness. It is hypothesized that decrease in cerebral metabolism could be the mechanism of action. Post-ECT hypometabolic state, like decreased cerebral blood flow and decreased glucose metabolism, may be related to its therapeutic response. Coming to cellular mechanism, ECT increases the threshold for future seizures and mood disorders. So future episode may be delayed. And neurochemical changes, all the neurotransmitters and receptors are affected after ECT, mainly adrenergic receptors and dopaminergic receptors. Second messenger system, change in calcium entry into the neurons were one of the mechanisms, and increased activity of adenyl cyclase and coupling of G protein to receptors. Indications for ECT, major depressive disorder and bipolar depression, failed medication trial, severe psychotic features, active suicidal and homicidal intentions, marked agitation and depressive stupor, melancholic features, poor oral intake, manic episode, failed response to mood stabilizers, severe agitation, and schizophrenia, failed response to antipsychotics, more effective in positive symptoms, and catatonic schizophrenia. Other medical conditions like catatonia due to other causes, NMS, Parkinson's, other acute psychosis, and intractable seizure disorder. Procedure. First, we have to do a pre-treatment evaluation of the patient and their medications. Physical examination is of very important. Laboratory investigations like routine investigations, routine blood investigations, chest X-ray, ECG, dental examination, X-ray, spine and brain imaging if we are suspecting any vertebral column injury. Concomitant medications, ongoing medications should be assessed, for example, mood stabilizers, benzodiazepines, and antipsychotics. As the antipsychotics, as such, they decrease the threshold for seizure, and benzodiazepine, they increase the threshold for seizure, and the mood stabilizer, anti-epileptic agents, they also decreases the threshold for seizure. So preparation for ACT. First, we have to keep the patient nil per oral for 6 hours. Denture and oral cavity should be examined. Bite block and IV line should be placed. 100% oxygen at 5 liters per minute should be given to be stopped at the time of electric stimulation. Injection atropine 0.3 to 0.6 milligram IM and injection glycopyrrolate 0.2 to 0.4 milligrams 30 to 60 minutes before anesthesia. Anesthesia used as general anesthesia with oxygen. Mostly we use thiopentone 2 to 3 milligram per kg IV. Others which can be used are methotrexate L-fentanyl, ketamine, etc. Low doses should be used to decrease the side effect and anticonvulsant effect. Muscle relaxant to decrease the risk of fracture and post-ictal body pain and injury. Injection succinylcholine 0.5 to 1 milligram per kg IV. And atracurium can be given to the patients with who are having pseudocholinesterase deficiency. Effect is marked by presence of fasciculations and its disappearance indicates full relaxation. Now, treatment procedure. Electrodes can be placed in two manners, bitemporally or unilaterally. Site for bitemporal is it is imaginary 1 inch above the imaginary line connecting tragus and lateral canthus, external canthus. And for unilateral, it is non-dominant hemisphere, either frontotemporal or centroparietal region, as shown in the figure. Now, electrical stimulation. Electrical stimulation can be delivered by a variety of waveforms. Waveform is the shape of stimulus as function of time. There are two waveforms most commonly used: sine wave and brief pulse waveform. Sine wave is currents are characterized by a continuous stream of electricity that flows in alternating direction. No number of alterations in direction or cycles of negative and positive current flow is referred to as frequency of the stimulus, measured in hertz. And in brief pulse waveform, it is like sine wave. It is bidirectional, alternating negative and positive phases, consists of series of instantaneously rising and falling rectangular phases of current as shown in the figure, with adjacent pulses separated by brief periods of no electrical activity. If you can see here. And coming to seizure threshold is the amount of electricity necessary to induce seizure. So it varies in males and females. More in threshold is more in male than in female, more in older than in younger. So starting with the dose less than the seizure threshold and increase with 100% of unilateral and 50% of bilateral until threshold is reached. This is the chart of how to optimize the monitoring of ECT. Monitoring clinically, planters are extensive, planters will be extensive. Seizure can be monitored clinically by inflating the BP cuff machine above the ankle and pressure kept is more than the systolic blood pressure before infusing the muscle relaxant. EEG and EMG recording are gold standard. Significance of duration of seizure. Seizure for at least 25 seconds is considered to be effective. Seizure more than 180 seconds is called prolonged seizure. Seizure episodes appearing later after ECT session is called tardive seizures. If up to 4 attempts of stimulation is failed, then session is postponed. Post-treatment care of airway and clearing any secretions, 100% oxygen till the beginning of the spontaneous respiration, and after recovery assessment of cognitive functions to be done. Adverse effects and their management. Adverse effect can be headache, confusion, and delirium. They are short-lasting mostly. If more than 30 minutes, can be treated with NSAIDs and benzodiazepines. Body pain, injuries, and fractures, they can be treated symptomatically, like with NSAIDs and muscle relaxants. Nausea and vomiting, this to be treated with metoclopramide and ondansetron. Memory impairment, both anterograde and retrograde amnesia can occur. 75% patients can complain of amnesia and may persist up to 6 months. Factors which determine impairments are type of stimulus, like sine wave produces more memory impairment than brief pulse, bilateral more than unilateral, and more than 3 times per week session, they are responsible for more memory impairment. Multiple seizures per session, supra-threshold stimulus, and concomitant use of lithium and high dose of anesthetic agent could also lead to memory impairment. Treatment schedule: 2 to 3 times per week session should be given. For major depressive disorder, 8 to 12 sessions And for mania, 8 to 20 sessions. For schizophrenia, 10 to 15 sessions, and catatonia, 1 to 4 sessions are enough. Continue treatment up to maximum therapeutic response, which is determined by static improvement after 2 consecutive ACT sessions. Coming to maintenance ACT, mainly it is indicated to prevent relapse. Inability to take, there are some indications like inability to take medication, severe symptoms with depressive features, history of high rates of relapses, and can be given weekly, bi-weekly, or monthly. Documentation is very important. Informed consent should be taken from the patient. All the procedures should be properly documented, including seizure events, anesthetic use, and post-ECT recovery. And symptoms response should be documented before and after each session. Contraindications, there is no absolute contraindication for ECT. However, it is not preferred in patients with space occupying lesion and raised intracranial tension, patient with prior history of myocardial infarction, recent attacks less than 2 weeks, but can be given after 3 months. And the patient with hypertension should also not given, because ECT causes increase in cerebral blood flow and increase in chances of hemorrhage. So BP should be controlled before ECT. Mortality following ECT rate is less than 0.01% for each patient and less than 0.002% for each treatment. So mainly and mostly mortality is due to cardiovascular and cerebrovascular accidents and pulmonary complications. ECT in special population. Pregnant and lactating mother, ECT has nil teratogenic and neonatally toxic effects, but more chances of GRD and aspiration are there. Fetal heart sounds should be monitored before and after ECT, and near-term pregnancy has a chance of fetal distress, so resources should be available for obstetric and neonatal emergencies. In elderly population, better outcome than younger. Threshold is given higher, as told before also. Higher chances of cognitive impairment are there in elderly population. ECT in child and adolescent. Indications according to the different guidelines, NICE, ACAP, and APA. According to the NICE, general indications are severe symptoms after an adequate trial of other treatment options has been proven ineffective and or when the condition is considered to be potentially life-threatening. According to ACAP, failure to respond to at least 2 adequate trials of appropriate psychopharmacological agents accompanied by other appropriate treatment modalities. And according to APA, other viable treatments have been ineffective, or if other treatments cannot be administered safely. In mood disorders, according to NICE guideline, yes, we can give ECT for major depression or prolonged or severe manic episodes. And other guidelines also consider ECT appropriate for mood disorders in children. For schizophrenia, NICE guideline does not recommend ECT, but other guidelines, they recommend ECT. Catatonia, yes, all the guidelines recommend ECT in children with catatonia. Intellectual disability, it is not recommended. Self-injurious behavior and aggression, it is not recommended. Adverse effects and special considerations in children and adolescents. An ECT-related mortality rate was estimated at 2.1 per 1 lakh treatments. The known adverse effects of ECT in adolescents are similar to those reported in adult populations like headache, nausea, muscular pain, confusion, and transient memory impairment. The available literature does not suggest a greater level of cognitive dysfunction in children and adolescents after ECT as compared. Patient given ECT did not differ significantly from controls in school or social functioning. 2 main complications merit caution when performing ECT in adolescents, the first being prolonged seizures and the second being tardive seizures. Prolonged seizures are defined as seizure lasting for more than 180 seconds and may occur in up to 10% of the children and adolescents treated with ECT, compared with 1.1 reported in adults. Tardive seizures, they are rare but potentially a serious adverse effect. Propofol as an anesthetic agent may be useful alternative when prolonged seizures are feared because they shorten the seizure duration. Some do's and do's like cognitive assessment before and after, and at 3 to 6 months is necessary after ECT, and bilateral electrode placement may be more effective than unilateral in manic patients, especially in patients with catatonia. ECT should be given. Unable to take nourishment and floridly psychotic, severely suicidal, bilateral treatment is recommended. And use of brief pulse and an adequate dose of electricity are recommended. ECT in youth should start at the lowest possible electrical dose that is sufficient to induce a seizure, because younger patients have a lower seizure threshold and therefore may have a higher risk of protected seizure. Now, status of ECT in India after Mental Health Care Act 2017. Is ECT banned? No. As per section 95(1)(a) of MHCA, use of ECT without the use of muscle relaxant and anesthesia is prohibited procedure. According to MHCA, unmodified ECT cannot be administered in a patient of any group, any age group. And section 95(1)(b) of MHCA states that ECT for minor is a prohibited procedure except in situations when the treating psychiatrists feel the need to use the ECT. Section 95(2) states that notwithstanding anything contained in subsection 1, if in the opinion of psychiatrist in charge of a minor's treatment, ECT is required, then such treatment shall be done with the informed consent from the parents and prior permission of concerned group. It is also important to remember that as per the section 94 MHCA, ECT cannot be given as a part of emergency treatment. These are my references.
Thank you. Technology saved us today. So,
Technology spoiled us also today.
I guess that shows that we all are human beings. So, I think very important topic for the first years, newcomers, and exam day residents. So, I think the topic is open to discussion. Any comments and any queries? Dr. Veena.
How many seizures can be given? First seizure is the
As per, we can give 4 sessions. Actually, sir, the manual of PCT is sir. Yes, no, sir. It is for foreign also, for Abraham.
Specific. How many we have given?
Like that.
In our residency here,
How many
in one day.
How many sessions? How many buses we can give?
How many basically failed session, failed session?
We one failed motor seizure that was we must define what is a failed seizure. Then, so you cannot say that there is no seizure just by. Okay, the question is how we confirm that there is an adequate seizure. What is an adequate seizure after giving an epilepsy? Then we will consider that we have to give next stimulus or not. Even if we see a motor seizure, if it is not an adequate seizure, we have to repeat. So then we must know how many electrical stimulations we can give. So what is an adequate seizure? Anybody? None of us know. What is an adequate motor seizure? What is an adequate EEG seizure? And there is a third way to measure seizure also. You guys know. Then only we discuss that how much seizures we can give. Excellent. 25 seconds, I remember, you must know the reference also. 25 second motor seizure, adequate seizure. What's an adequate EEG seizure then? 100 to 120 seconds. take 100 seconds. We can again review it. As far as I remember, it's 100. Now, if we don't have an easy facility, and for some reason, such as something else, we are not getting a motor scissor and we don't have an easy facility. How will you measure scissor and better adequate scissor in that? There is one, at least one another method, but there are more than one actually, but at least one which I remember. अगर easy तो नहीं है, motor scissor आया नहीं, probably कुछ original scissor तुमने कहा ठीक से नहीं बांधा लेग में, तो हम कैसे measure करेंगे? Increase in the rate of heart rate from resting lasting 30 seconds is considered adequate. Now, अभी अगर adequate scissor पहली बार में नहीं आया, तो अगर मान लो 10 सेकंड का आया, will you repeat it or not? Yes, yes, it is 10 seconds. Motor scissor आया, will you repeat it? तो फिर अभी कितने repeat कर सकते हो? Then there is a different again different opinion. Personal opinion जब हम लोग करते हैं, that is 60. और आपने
Yes, sir. But yes, sir, but clinical practice में भी हमने मतलब mostly 3 के बाद नहीं दिया है. And that too with oxygen for 2 minutes.
Basically, if you speak more than 2 attempts, they say that the sub-threshold post-synaptic potentials, they submit and they by 3 they actually make a potential. So they say that when 3 attempts are failed, no logic of going to 4. But this is the physiological aspect. But I have personally, when we were doing residency, after 2 attempts, we used to leave because of sighting problems. But there is one important issue, as Dr. Sumit was raising here. If you give a Caesar, 10-second Caesar comes, after how much time you will immediately give a second Caesar? Actually, absolute refractive period is 60 seconds. Wait for 60 seconds. Why I tell you, there will be a theater there. An anesthesia was staring at you, and you put the electrodes, and then you are looking at them, no Caesar. Out of anxiety, you tend to actually give it more quickly. So explain that, we'll wait for 1 minute. Otherwise, chances of second failed Caesar will be high. How much electricity, how much the strength you will increase? Will increase or not? Specifically, here, which kind of an Caesar modulation you are giving? You're giving bilateral, unilateral, you know, bilateral, sine wave or brief wave? Sine wave, frontal, bitemporal or frontotemporal? They are giving frontotemporal. Bitemporal. तो इसमें कितना बढ़ेगा?
25%.
For
क्या पढ़ा? क्या पढ़ा? मतलब वो हमारे पास तो मशीन है, I use that, मतलब मैंने कंपनी में जो फाइनल जूल्स को दिखाता है, वो तो आपको सेट करने पड़ेंगे. वो आप टाइम भी बढ़ा सकते हो, करंट भी बढ़ा सकते हो. हमें फाइनल जूल
frequency is supposed to be increased at the last. Basically, initially you will just increase the time of duration of input, and 25% for females and 50% for males, because there is a difference in male and female Caesar threshold. One more important factor for increasing Caesar threshold is
They mentioned one important Caesar threshold. They mentioned at least one Caesar very good. Caesar threshold.
ECT के सेशंस में ही एक फैक्टर ऐसा होता है जो Caesar threshold बढ़ाता है. वो क्या होता है? खुद Caesar serial ECT sessions will increase Caesar threshold automatically. So 4 Caesar coming as a failed Caesar, you should not panic about it.
One case where you prefer unilateral ECT. Caesar threshold with the age. How it is mentioned, but
Bilateral का क्या complication है?
बताओ bilateral उससे clear हो जाए.
इससे भी हो जाए, कुछ unilateral पे
English already हमने बताया उसमें. So then in which case you prefer unilateral? Yes, unilateral prefer that is unilateral ECT, of course. Yes.
Have we given unilateral there? We don't have. Costa, you have any experience? They'll give bilateral. And Dr. Sanjeev, because you only read in the books.
नहीं सर,
They don't have any
CIP
experience with
सर CIP में स्टडी हुआ था यूनिलेटरल
हुआ था?
हाँ, one of our colleagues अंकित, because सर वो ब्रीफ पल्स थेरेपी वाला मशीन चेंज हो गया था, तो फिर then we had a study on it.
I have a question. lot of people say if you receive an ECT and you improve with ECT, you will subsequently only improve with ECT. Is it evidence-based statement? Evidence-based statement. इसका evidence है? Yeah, I don't know. अच्छा, whether this we find in our practice? Clinical encounter. Many times we see patients with, basically, I think we all see patients who more or less, who comes to us, have received a lot of ECTs. And subsequently they respond with there can be some bias, we may lose some patients. Very importantly, the integration. So when those self-injurious behavior, they are not recommended. And many times in here in this setup, a lot of private practitioners are giving left, right, center ECTs in mental health patients with injuries, behavioral problems. So this is absolutely unethical. But no Indian guideline. Indian guideline.
Indian nice on API.
Section 95 also when psychiatrists consider you can give ECT to minors. Without consideration of psychiatrists, when where you can give it.
And MSC also says that it cannot be given as an emergency. That means you have to admit him, keep him for a few days, and show him that he is not responding, and then give him.
Yes, sir.
Minor में तो permission
Minor
नहीं
में
है.
permission है, central.
Then there are now people saying that patients who relapse after ECTs, then you taper the ECT sessions, like you taper medications. Now it's not more than thrice a week, then twice a week, then you have to quickly stop, then once in a month maintenance. They are now bringing up some data that now you have to actually do it then once a week and then once in 2 weeks. Tapering करके, they are saying the patients specifically who relapse is very quick. How it acts? Another question. Like it is like a neurosurgeon, a surgeon who is operating, he doesn't know how. Basically, thing we give, but we don't know how it acts. Do we have any complete answer apart from all those hypotheses? Some says it reboots the system. It's like an antivirus. It stills
So
everything.
some hypothesis about BDNF are also there that it increases BDNF levels and which is
That is our patient with medical criteria. Given ECT at some place, subsequently when it would be on education. Keratonia followed in 2 to 3 years. Any other questions? I think the interns are very fascinated by ECT. Have you observed any ECT here?
when I was posted in child, I used to see we have to give more sessions to the younger population and then the adult population. I don't know the reason, but I have observed this. I don't know why they never settled in like 2 to 3 sessions they take to just calm down. So,
There is a good evidence that ECT is more effective at this process.
oh,
Very important topic. There are a lot of questions you can ask.
ECT, larger ECT varies from different areas. Like circulars also negatively portrayed about psychiatrists.
in the 1950s, it was like, degradation in the use of ECT also because of media playing the role. They used to portray it in a negative way. There were movies
I
where
wonder if we have any fashionable helmets kind of a thing. We ask the patient to wear and then seizure is induced. It will be much less stigmatizing. है ना? मेरे articles में helmets ना आ गए हैं, सब चीज़ helmets ना आ गई हैं. Neurosurgeons are going for all those surgeries. Surgery is less stigmatizing than giving ECT.
I actually wanted to find the problem. मैं पेशेंट को क्या बोलूँ? मतलब मैं उसको सही
Absolutely.
बताऊँ कि मैं
Very
इसके
right.
करंट दे रहा हूँ देखो
Exactly.
ताकि क्या मैं उसको मतलब मेरे को पता है कि वो उससे बेटर होगा और मैं उसको ऐसे कर दूँ कि
And we hate saying this current. It was all words that current के अलावा.
अरे मतलब मेरे को wording
Correct
नहीं
लगेगा.
पता है. That's what I'm discussing. मतलब I want to be very honest with the patient और मैं actually बताना चाहता हूँ लेकिन मेरे को पता है सच बताऊंगा तो लेगा नहीं और
Then the demand that's safe.
Then he'll ask you
Yeah,
what,
Sakai.
sir, what Uja, sir?
Sakai.
He'll ask you what Uja, sir. I'll discuss it with my family. And then they'll have some Ayurvedic doctor or something. And then they'll say, देंगे तो ये खराब हो जाएगा.
We also want medical treatment we have to be able to contain. Actually, INC वाले ना वही agree करते हैं बाकी.
Yeah, I think somehow the people who are actually giving ECTs in private practices here or near by places, they're actually helping us. Because those patients subsequently are not stigmatized about ECT in a way. ECKI कर दिया and all those things they use.
Even they have come to our department and asked sir, कि ये वाला है क्या? Actually they asked. Very effective and very safe. They don't outline stigmatized, but
I think durations also you need to see कि prolonged seizure क्या होता है. Then as Professor Smith said, what is a sub-shock, sub-seizure, motor seizure duration, electroencephalographic seizure duration, motor generalness, electroencephalographic generally more. So those things we need to see. Nowadays the consensus is coming, don't rush up for multiple sessions in one session. Even if you have a sub-seizure or sub-shock, wait for the next day. If patient is clinically improved, then seizure must have happened, not noticeable. And specifically in our practice, we don't do an EEG of the patient. We don't know. And then here also the muscle relaxation will spread down. So here we should not rush up. हम चार लेके रहेंगे. आज तो सीधे निकाल के रहेंगे. आज तो दौरा आना ही चाहिए. If we can wait for the next day, see patient improves, then it's an indirect clinical indication that this thing is happening. Can anyone do cardiovascular physiological response?
is a specific type of response.
Anyone? Go ahead. Go ahead. Go. Huh? One of them is the most common reason for cardiovascular mortality. Huh? MI. Arrhythmia. Something in your case is told. Heart goes into case is told. And then subsequently, sympathetic surge comes in.
Goes into arrhythmia, say, so what do you do? Feel that something is happening. There must be an accident which should help you. क्या है? Severity क्या कर सकते हैं? और कौन है? लिखा है आप क्या करोगे अगर मतलब एरिथमिया हो जाए तो आप क्या करोगे मेंशन है वो हम इसलिए मेंशन है कि सबको पता है कि आपके पास क्या है उसमें आप एट्रोपिन लोगे ओके एट्रोपिन आपके पास है वहां पे आप एट्रोपिन ओके एट्रोपिन से प्रॉब्लम हो सकती है बता सकते हो अगर तो प्रैक्टिकल इससे क्योंकि प्रैक्टिकल डिस्कशन है तभी आप देंगे इसमें रहेंगे एट्रोपिन होगा तो एक प्रॉब्लम हो सकती है वैसे भी होगी वो लेकिन एट्रोपिन से हो जाता है एमबीबी हो सकता है मतलब ये सारा सेंटर एट्रोपिन पहले एट्रोपिन दे दिया है तो उसमें कुछ नहीं करना है उसमें जस्ट वेट करना है यदि 30-45 मिनट जो बताया है मैंने
डायरेक्टली तो हम यहाँ पर used to pre-medicate with atropine. Used to prepare patients. And also it is an assessment if the patient is on tricyclic. Telling he already is receiving anticholinergics, so they might reduce the dose. Because direct ECTs used to not give atropine injections because the tricyclic we never used to give it. Only you can license them. And you can also license patients having some morbidity or something, which anesthetic begins to use in some relaxation or the induction units. That's a very interesting. Yes. Dynamic interaction, kinetic interaction, any of the
One thing I read, sir, about ketamine, that ketamine is an antagonist, an MD antagonist. So, It increases the latent long term potentiation को increase करता है and it leads to decreased cognitive impairment. So Patrick Ketamine is safer.
Okay, any other questions? Closing comments, Dr. Kaustubh?
Absolutely important topic about the examinations and man has covered PDM also and the other side.
I have seen there are a lot of hospitals, family members accepting and signing the consent form, but patient is not accepting, willing to do the ECG procedures. The secretary also says that they are doing some scans, like CT scans, other scans, for 15 minutes. You know, आँख बंद करना है बस हो जाएगा. So as per mental care act says, patient जो बोल रहा है हम करना है, but still it is violations of mental health care.
Nice conversation. I just remember a case like we had. She was bipolar and OCD. We gave her ECG for bipolar manic episode, severely manic, and after that she forgot her OCD. I mean, she forgot that she used to have such obsessive thoughts. But later she developed after a few months again she had, but immediately after she said her case presentation was going on when she was the manic episode. And so the presenter is like talking about the OCD and all, and we asked the patient. So we are asking instead, so ये कब था मेरे को? So it was kind of funny. Really, sir, cognitive impairment.
Dr. Sumit?
Very nice, but not the stay your presentation. So आप लोग but we have discussed.
This was an opportunity to read ECT. Finish ECT here. You need not read it in the next few years of your life.
आप अभी रीड करके आते हो ये डिस्कशन हो जाती है जब एक बार हो जाता है नहीं
So, Dr. Meena, well presented. You have taken pains to teach us. Hopefully, not more presentations from the side. One comment. One of the very senior psychiatrists, I think, what the extrovert knows. Patients have told us, sir, हमें अंधेरे के कमरे में ले जाके बिठा दिया गया है, इंजेक्शन लगाया, फिर जब हम उठे तो हमने कुछ सोच लिया. So kindly avoid these kind of practices. Educate them in today's circumstances and very expensive. Educate them, they are not able to take it fine. Otherwise, long term,
प्रॉब्लम नहीं लगता लेकिन इसको भी लगता है आप